HIV does not happen in a vacuum, and human beings don't live their lives compartmentalized. And nowhere is that more apparent than the topic we're going to talk about during this next segment. We're going to talk about HIV resistance, we're going to talk about comorbidities and co-infections, and we're going to talk about the opioid epidemic. There's a relationship between these three topics, and we have experts here that are going to help walk us through those relationships. We're going to start with Carlos Perez. Carlos is with the Catholic University of Chile. Thank you for being here with us. Also with us is Nora Volkov from NIDA, and her sister Patricia Volkov, who is with the National Institute of Cancer in Mexico. So let's get right at it, starting with you, Carlos. So today you're doing you're co-chairing an oral poster on the resistance and why we must care. So why should we care about resistance?
Well, HIV drug resistance is a growing problem all over the world, and it's the reason why the WHO 2 years ago developed a global action plan to monitor, to prevent, and to respond to these increased levels of resistance all over the world. So in this wonderful session, we will have the opportunity to review what is happening right now in Brazil, where the trends show that the resistance levels are decreasing. In contrast, in Africa, we will review data on naive patients who never received treatment, but also in experienced patients who are failing their regimens in many different countries. We will hear about Cameroon, Uganda, Malawi, South Africa. So very interesting information that is complementary with this plan that the WHO has.
And as we talk about resistance, it gets exacerbated and complicated when we think about co-infections and comorbidities. You know, when we think about today, now in the HIV/AIDS space, we cannot only be concerned about HIV. There's the issue around hepatitis. There's the ongoing issues around STIs. You know, we can throw in other things like mental health and drug addictions.
The opioid epidemic is just making us very clear that we cannot keep on ignoring drugs. And clearly, if you are addicted to opioids, and you're much greater risk of getting HIV. But if you treat it, you actually are going to prevent that person from, on the other hand, infecting others, and it will improve their outcomes. But I do want to, in linking to what was just described about the issue of resistance, why it's also very, very important, because one of the reasons why clinicians sometimes do not provide antiretroviral therapy to people that are addicted to drugs is because they are afraid that by treating them with antiretroviral, they are not going to be compliant, and then are going to be promoting basically resistance. However, what the data clearly shows is this: if you provide treatment for the addiction and for the HIV, the resistance actually goes down, and because you are minimizing that likelihood that these individuals will infect others. So the message is, if while drug use contributes to HIV, if we prevent it and treat it, we significantly improve outcomes, and we also significantly decrease the likelihood of resistance if we properly treat people that are injecting drugs with antiretroviral therapy and with a medication for the opioid use disorder.
And the truth of the matter is that the data tells us that people who use injecting drugs have figured out ways to be compliant. And those tools, that skill, can help them be adherent with their ARVs as well.
Yeah, no, totally. And in fact, one of the aspects that has been a priority for us is to try to integrate the models of care. So for example, I see my sister, who's an infectious disease doctor, managing extremely complex medication regimes. So my question is, why can infectious disease doctors not integrate the treatment of the medication for the addiction? And the data shows that in fact their outcomes are as good as those dealing with specialized treatment programs. So absolutely, we need to stop discriminating people with addiction and start to screen them and treating them for both of those diseases.
And Patricia, you focus on co-infections and comorbidity. And so in that scheme, there are a number of disease states that we have been aware of are important in HIV space for a long time. STIs, now hepatitis, tuberculosis, to give a few.
I will co-infections with virus that ended on malignancies. Okay, and I think HPV is a very important problem because it's not only for women but also for men. There's a greater risk of neoplasia associated to HPV viral infection, and a woman can be affected in first with cervical cancer, and during the follow-up, 6-7 years, meaning treatment, she can develop vaginal cancer or vulval cancer. And we also have the problem with Kaposi sarcoma, that is usually a disease that presents when the patient doesn't know he's infected, okay? And I think hepatitis B, EBV, I think they're in this scenario, and they will be, I think they will going to be very important in a near future as they are oncogenic viruses. And patients, even in treatment, develop lymphoproliferative malignancies. So, as you said, they are not compartmentalized. Indeed, there are a lot of virus, of co-infection with virus that are oncogenic in the population of HIV patients, and we really have to be aware of it and screen for it and treat early.
And so I've not heard anyone raise Kaposi sarcoma in a long time. Now, I've been involved in the epidemic since 1982. I've been HIV positive since around that time as well. And in the early days, we talked about Kaposi's all the time. So can you unpack that a little for us?
Oh, yes. You know, in the early epidemic, 30% up to 50% in some areas of the patients with HIV developed KS. But the scenario was changed with the introduction of combined antiretroviral therapy in high-income countries. But this has not happened in Africa, where it's still the first malignancy, AIDS event, and there's a big burden of morbidity and mortality in HIV-infected patients. And this is related because this virus and HIV in immunodeficiency, and in these countries, many people are diagnosed late because this is a disease that appears in patients with severe immunodeficiency, the Kaposi sarcoma.
And so if we're seeing Kaposi, are we also seeing pneumocystis? Are we also seeing cryptococcus meningitis as well in these countries?
And histoplasma in this country. We had a lot of histoplasma in our country. So we are seeing patients with advanced disease with these complications that are not so frequent anymore, neither in the USA, neither in Europe. But why? Because people have access to antiretroviral and good care.
And so given that we need to make sure that we're fighting these co-infections and we're building strategies so that we kind of move some countries further up, and maybe prevent some other countries from not going back. It seems to me that resistance actually becomes an even bigger issue in that conversations. So here at 2019, IAS 2019, Carlos, what are we doing here to specifically address the conversation or the topic around resistance?
Well, the main issue is really to know exactly what is happening in every country around the world, because there are different, even regional differences in countries, in different countries. So we need to know before we start treatment in many countries, because the resistance rates are higher than 10 or 15%, and definitely after failing antiretroviral regimens. And this is not happening everywhere. There are regimens for second failure, third failure, without doing genotyping, and that is the studies we are going to hear today, are going to show us that it's very important to have that information before deciding what is the best regimen. Otherwise, we can fail, if we don't choose the right drug for the right patient.
And given the maturity of the ARVs that are available, are we encountering resistance among treatment-naive patients? Are we encountering that already, or are we concerned about that?
Yeah, well, when we're talking about resistance, we are talking about transmitted drug resistance. So people who never received treatment before, and they have already resistant viruses, 10%, 50% in some countries. You know, of course, people who have been on antiretrovirals and the adherence has been poor, or they have suffered for stockouts of drug. That is a very common problem in some countries in Africa. They can also develop acquired viral resistance. But we are talking about transmitted drug resistance for patients naive to drugs, you know, and they are already resistant. At least for the drug we used to use in the past. You know, now we are choosing a regimen that are more potent, you know, and that can be useful for this patient even if they have resistance.
There's an elevated conversation going on in this meeting around 2 drug therapies as opposed to the triple cocktails we've talked about. Are you concerned at all about the potential impact on resistance as we move towards 2 drugs as opposed to 3 drugs?
Yeah, there is always a concern, especially in people who are going to have in this 2 drug regimen are going to have, for example, 3TC or some, you know, non-nucleoside transcriptase inhibitors, and they, you know, may have acquired a virus already resistant. So at the end will be on monotherapy, you know, a potent drug but monotherapy. So there is always a concern, and to make a decision when if you are going to recommend for everybody, you know, a 2 drug regimen, you have to know exactly what is happening in that region, you know, with regards to transmitted drug resistance.
Thank you. Nora, as we wrap up, today, are there specific sessions today or tomorrow that you would recommend people go to?
Yeah, in this afternoon, there's going to be a panel to specifically address the unique challenges that people that are suffering from a substance use disorders have in terms of accessing treatment for their HIV disorder, but also on what are the challenges that systems have in terms of providing that level of help. And importantly too, I think one of the aspects that we need to put in the table is the stigmatization that people that are taking drugs have to deal with in their communities and in the healthcare system. And this is an opportunity again to change that narrative, because if we don't address their treatmental needs, we won't be able to control HIV. I mean, it's necessary.
And what about you, Patricia? What's your hit list for today? What are the things that people must go to today?
Well, we have co-infection comorbidities that are mainly co-infections, fungus and TB sessions, that I think is going to be very important, mainly in Africa.
Great. Nora, I'm glad that you raised this around stigma. That actually is a topic that we're going to talk about next. I want to thank all of my guests for this really important conversation. And next up, we're going to talk about stigma. All week we've been talking about the science of HIV. We've been talking about preventive science, therapeutic science. We've been talking about the research. We've been talking about basic science. But the truth of the matter is that all the science in the world will not make a difference if people don't understand it, if they don't believe in it, if they don't have access in it, if they don't use it. And one of the biggest barriers that prevents access and utilization is really the question of stigma. And that's what this segment is all about. With us today to walk us through the conversation around stigma, we have Lucy Stackpool-Moore, who is with IAS, part of the IAS family, and we have Junior Blair, who is from Jamaica.
Okay.
And so welcome.
Thanks, Phil.
So let's just jump right in. So now, Lucy, I know that you are running a program talking about getting to the heart of stigma. Mm-hmm. So what does getting to the heart of stigma mean?
Well, it's a great question, thank you. And I think for us, stigma is something, we don't want to have it just something that is for academics or for conferences or for those big words. Stigma is an ancient Greek word, but it's really something that when you think about it, it's very much here. It's the heart that we all have. It's the heart that we have in our hands here, but it's around how can we start those conversations in our own lives to have the courage, the conviction, the perception to do something about stigma if we experience it ourselves, if we see it in the clinical setting we work in, if we notice in the kind of research that we're doing. Let us all have the courage to start that conversation, to acknowledge where stigma happens and to really do something about stigma really in a big way at scale, because blows my mind that still 40 years into HIV, to this epidemic that we live and breathe every day, why is stigma still an issue? Why can't we do something about it? So for the IAS, we're really thinking it's not something new. Let's scale it up. Let's be meaningful about what we're doing. Let's engage the hearts as well as the minds when we're talking about stigma. So that's, for the IAS, that's what it means, is to really get to the heart of stigma.
So now IAS 2019 is, for lack of a better reference, is the science meeting.
Yep.
Okay.
Yep.
As opposed to AIDS 2020, for example.
Yep.
So is there a science to stigma?
Yeah, it's actually exciting to see stigma in the program through abstract-driven sessions. We have one tomorrow that's really looking at the measurement of stigma and how things have moved on, and different indices and robust analysis of stigma, which is so important because I think we need to be very precise in terms of what we're talking about. But equally, we ran a workshop yesterday that was very interactive, very much based on life experiences, and it's a workshop we've done in other AIDS conferences, not the science conferences, but to actually look at there is a role for those important conversations, for life stories, for emotion, for empathy, and to bring in the human side around stigma, the heart, right? It's not something that needs to be separate from the science. Actually understanding stigma, feeling stigma, and then measuring it accurately, they're all part of the same package. So it's thrilling to see such a strong engagement with this campaign at the science conference. And I was with some colleagues yesterday in a press conference, and one of them was so passionate. And I said, who says scientists can't be activists? There's a lot of people here who are really committed to ending stigma, scaling up attention to stigma, and let's marry the two. Let's see how science can support activism and vice versa so that we can actually get to the heart of stigma.
And understanding the relationship. I think all the scientists here want to have an impact now, and their science, their work in the labs, their work in the clinics won't have an impact unless we're able to address these fundamental barriers to utilization. Mm-hmm. So, Junior, you're doing a lot of work in Jamaica. Congratulations, and thank you. Yeah. And you've recently been nominated for the Me and My Healthcare Provider Champion.
Yeah.
So what is that, why did you get nominated?
Okay, so it was a campaign that was going on for JM Plus, introduced it to the treatment sites. So basically, it's like from the key population, you would identify persons who are healthcare provider who display good quality service. So if it can be the doctor, the receptionist, or somebody who really deliver good service to you, not really shun you or make you feel like, oh, I'm not going to come to treatment site or so, but you're receiving good care.
And so, what about the care that you're providing in Jamaica that sets you apart from other care providers?
I think everybody's doing excellent work, but for me, what I do, really, I try to really focus on patient-centered care. So we all know it is a very sensitive topic, and persons from key population, sex worker, MSN, so said they're really kind of sensitive. They really identify themselves. So if you come across a person from the key population, they are looking for if I'm going to really reveal something or more information about myself, you're supposed to be compassionate, non-judgmental, and understandable, and pretty much be knowledgeable too, because they're going to come to you for information and where I can go to access certain things that would benefit them.
If I may, Phil, and jump in, Junior's being a little bit humble here. I think one of the things to really acknowledge is the Me and My Healthcare Provider campaign is to really recognise the incredible work that healthcare workers like Junior do in the face of prevailing cultural norms or social norms or discriminatory laws and policies that makes it like a disincentive for healthcare workers to do the right thing. And yet, despite those norms, people like Junior, really who've taken that Hippocratic oath quite seriously and really embrace what it means to be a healthcare professional in whatever level that is, but to really do the right thing, which often takes a lot of initiative and courage despite pressures from society and family often or peers, and And so it's quite incredible within some of the contexts. And Jamaica is an example at the minute where it's a
Yeah,
lot of
yeah, because the stigma and discrimination in Jamaica is really bad and high. So honestly, you just really have to just, even though it's your job, sometimes to me it's personal. It's a personal job because you're working, but sometimes you get attached to the clients then, and you really want to see them doing good. So you really do your best to try to make them reach their goals.
And so I have two questions tied to that. One is the phrase patient-centered care. You know, I've been involved in the epidemic since 1982. And over these nearly 40 years now, there have become these buzzwords now. And what I've noticed is that we use the same words, but we don't necessarily have the same meaning. You know, and so when you say patient-centered care, what are the key elements of patient-centered care? And then I want to follow that up with a question about key populations and vulnerable populations.
Okay, so when I try to get the question you ask. So you say you want to find out from me what I think about why focus on.
How do you define patient-centered care?
How do I define it? Showing compassion and make sure that the clients are comfortable, respect their values, their preference, their needs of expertise, or it is pretty much can I get nervous?
Don't be nervous.
So basically you just, to me, I always tell myself this, alright, because like we say, if me I go do access service, and if me not get good service, I'm not gonna go there. So I wouldn't want to, like we were saying in Jamaica, do unto others, others do unto you. So I wouldn't want to not deliver good service to get bad service. So even though sometimes we do, like we say, you're doing good, but you still will receive bad service from persons. But you just have to like really understand that the stigma is there, and you just really want to encourage person, because you try to, like we say, you're really saying is that stigma it's going for years, or you really want to put a stop to it, because it cannot be a go so long. So honestly, you just have to like tell one-on-one with the clients them, like you need to understand to say you need to self-care, put yourself first. Don't watch no face, that's a Jamaican saying. Don't watch what others want to say or gossip, because sometimes we have to be like, I encourage them to be like activists, like to speak out, like, because alright, in Jamaica, if you have HIV, the first thing they're going to say AIDS. Or a person that have AIDS. So sometimes if they do, they can say basically you don't know the difference between HIV and AIDS. So I try to empower them to make them understand, to say sometimes you can control the conversation if negativity come across you. Yeah.
Great. And then the second question, a large part of our battle really is working within the cultural context of the communities in which we serve. And some of those cultural contexts, if I can be so bold in reference to Jamaica, are hostile environments when it comes to key populations. You know, when it comes to vulnerable populations, when we're talking about men who have sex with men, when we're talking about drug users, when we're talking about sex workers. These are all populations that are pushed to the margins, or in some cases worse than just pushed to the margins, who are actually demonized or even the subject of physical violence. So against that backdrop, can you share with us how you connect how you work to counter that backdrop in your work?
Okay, all right. So because I'm really from the rural area, it's not much MSN or like drug users in my area. or sex workers, because it's not really hot. But yeah, they are there, but it's for like, so if they come, I would probably like identify or like sense, or then what I can open up and have a conversation. Because one of the things with what I do with my clients, them when I see them, I said, or I would encourage them to say, okay, this is a service. You're coming here for a service here. Don't come out of the doctor office and you do not understand A or B what the doctor is saying to you. So that I try to encourage them on that aspect in ensuring that they understand the whole procedure and everything in the health sector or so. But you can kind of repeat by the question or so.
Well, I think that you addressed it, that understanding that there is a hostile environment and how you can provide individual and personal support in that environment. And I think that for a lot of us who are providing care and services, sometimes people forget about the personal support. We get so caught up in the labs and the numbers and the indexes and the metrics and that we forget about there's a person behind all of that. Lucy, I want to come back to the Stigma Campaign. And so if we're going to try to get to the heart of stigma, stigma manifests itself in different ways, depending on where you are. Depending on who you are, depending on how you receive the way people might react to you. So one size does not fit all.
Absolutely.
And so as IAS addresses stigma, how do you address kind of, quite frankly, the divergent ways that stigma manifests itself?
Oof, that's a good question. I think there's obviously, in the context of HIV, there's obviously lots of different types of stigma that's important. There's also stigma around HIV, there's stigma associated with behaviours, there's stigma associated with gender identities, and all of that's relevant, and yet all of that is quite different, right? And so I think for this campaign, we're trying to not be too nitpicky about which box of stigma we're talking about, but saying actually if you flip it around and think of someone's experience, how I experience stigma, it might be very hard for me to say if that's in relation to my gender or my sexual orientation or my HIV status. From my experience, I just feel a bit crap, I feel dirty or I feel not as good as I should feel. And it doesn't matter what that's about. For me, that's a crappy place to be, and we want to do something to address that. So it's trying to look at both the specificity of the type of stigma and the intersectional nature of stigma and those layers, but also acknowledging that actually from the personal experience side, maybe it doesn't matter. It's about let's make everybody feel good. Let's try and make sure that stigma doesn't create barriers for someone to go see their healthcare worker, to be open in that discussion with their healthcare worker. And if that's around more generally looking at things around self-esteem or confidence, knowledge, empowerment, those things, let's try and tackle it from that side, as well as the very precise way in terms of understanding the complexity and the multiple layers of stigma itself. And for this campaign, I keep holding this, but it is about the heart, and it's really recognizing how human stigma is. It's absolutely intrinsic to how we each live our lives, our own morality, our values, how we interact with our friends, our families, if you're religious, which I'm not, but our religious leaders, stigma is very much part of how we are as people, as society, and it's very human. And that's okay. It's that people need to have those things that's linked to how we function in our lives. But what we want to do is look at addressing the stigma that's preventing people from being the best version of themselves that they can and getting the best quality services that they need in life. That sounds very vague when I say it like that, but it's recognizing that we are never going to end stigma. It's always going to be there. It's very much part of societies and human nature. But let's get rid of the stigma that is preventing people accessing healthcare, that's enabling people to be vulnerable to HIV. That shouldn't be there. We can do something about that. And as the IAS, we can leverage our position and our membership base to really try and do that in a big way at scale.
And Junior,
according to what Lucy was saying, okay, so I understand that there's a lot of stigma categories. So what we are doing as JAME Plus organization, so basically we're trying to implement a tool, a community scorecard tool, so that would like highlight issues from areas, like it can be either operational issue, SND issues. So because you mentioned stigma and discrimination, sometimes they will say, oh, stigma, but you really have to kind of really dig deep to say if it is a major issue. You really want to find out if stigma is a big issue, because sometimes sometimes they speak like we say, oh, this person, like we say, some person have to say, oh, they define stigma. So you really want to say if from the community, when they give you the issue, you would like to say, okay, then I like to say, okay, then examine to say if this really stigma or self-stigma, because you can categorize them. Yeah.
I think that one of the issues that you just raised that is important is the notion of self-stigma, and how do you help people process that. But also one of the ways that stigma actually attacks people and sets up a stand is by dividing people, you know, and one of the ways that people can attempt to escape their own stigma is by practicing stigmatizing behavior against others, you know. And one of the things that I know in my culture, we talk about stigma being of a whole cloth, you know, and that the threads of the stigma, the threads of the oppression are woven throughout the entire cloth. So you can't just cut out the piece of the cloth that impacts you and still consider yourself just, as Dr. King would have said, Dr. Martin Luther King Jr. would have said, that you can't say that I'm opposed to homophobia, but yet embrace racism, you know, and you can't, you know, oppose racism and yet embrace, you know, misogyny, you know, or transphobia, you know, or, you know, develop these, you know, discriminatory practices against sex workers or drug users. That those threads are woven throughout, and understanding the otherness that stigma creates. So, as we look at fighting stigma, are parts of what are the actual elements of your campaign that our viewers can grab a hold of to understand that's a part of the campaign?
Thanks, Phil. I mean, they're very simple but important way is we're trying to create a mass movement. Sounds so ambitious, and it's really through things like social media. We have a hashtag here, Heart of Stigma, and we're really encouraging in the most personal of ways people to be inspired and to start that difficult conversation. If you see your father or your mother or your sibling at the dinner table making a comment, if it's around something that's racist or sexist or transphobic or is against people with HIV, then call it out, have that conversation. And that can be really hard in your own context, but that's where the change starts. We can stop the passing on of some of these values between intergenerations or within our families, within ourselves. Be honest when you look in the mirror and think, actually, yeah, I was racist this morning. I had this implicit bias about something. I want to be a better person. And I think it's really at that very, very individual level. We can all make changes on that. Nobody's perfect, so we're very human, right? And let's be honest about those values and those attitudes. Let's have that conversation. Let's have it on Twitter if that's your thing. Have it around the dinner table if that's your thing. Have it in the bedroom. That would all be one little step towards this big movement to actually make a difference around stigma.
As Dr. Martin Luther King Jr. said, everyone can be great because everyone can serve.
Yeah,
you know, there's a role for each and every one of us to play, and we succeed when each and every one of us plays our role.
Yeah.
So I want to thank both of you.
Can I, before we finish, Phil, can I ask you, I know you're a wise man in this space, I respect you immensely, but if you had to say for you what would be the real pearl of wisdom around getting to the heart of stigma, what would you say? How would you advise us?
For me, it is the human need for one to be better than someone else. You know? And if we understand that is such a huge source of pain, and that when we do that, what we're really doing is trying to excise the pain that we experience when someone else demonstrates that they think they're better than we are. You know, and so it is embodied in conversations about race. It's embodied in conversations about gender and gender identity and class and socioeconomic class. You know, so if we can find ways for people to feel whole without making others feel less. And that for me is the hardest thing.
Right. Thank you.
Thank you.
You're
Thanks.
welcome.
And thank you.